You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is July 24th, 2023. Our topic today, food allergy, part of our orientation series. Our presenters are yours truly, Dr. J. Portnoy, and Dr. Aarti Pandya. We're in the section of Allergy, Asthma, and Immunology at Children's Mercy Hospital in Kansas City, Missouri.
All right, we're at 11 o'clock. We'll move on for our second presentation today. I kind of pre-introduced it before, but again, it'll be Dr. Portnoy and Dr. Pandya who will be speaking to us today on food allergy.
Okay, can you see the food allergy slides?
Yes.
Okay, great. Welcome back. This is our second presentation today. It's part of our orientation series on COLA for 2023. And we're now going to switch gears and talk about food allergy, which I think is actually, I see more food allergy than I see asthma and rhinitis now. It's become what we do. It's what's for dinner. Here's the disclosures. I actually am a speaker for Thermo Fisher, and some of the testing for food allergy does involve their product, or they make IgE tests, so just to disclose that. These are the learning objectives. I'd like to start by just presenting a tale of two food allergies, just as an illustration. And so imagine 8-month-old Jack eating a small amount of peanut butter, and he gets a face rash. Pretty common scenario. This could happen, this could progress in two ways. There's Jack A and Jack B. In Jack A, the mother wipes the peanut butter off of Jack's face and the rash resolves. The rash is mentioned to Jack's PCP at his next visit. Since he now tolerates peanut butter, no further testing is done. An EpiPen, epinephrine autoinjector is not given. Jack subsequently gets rashes after eating several other foods. The mother again wipes the food off, gives Benadryl, continues to eat the foods. That's Jack A. Pretty common scenario. Now let's turn our attention to Jack B. It's the same Jack, but he also gets the rash on his face. But for Jack B, the peanut butter is quickly withdrawn and Jack is rushed to urgent care. A blood test is done for a food panel. Jack is given an epinephrine autoinjector and told to avoid peanut. At the next PCP visit, the food panel is revealed to be positive for egg, milk, and wheat along with peanut. And though they have been tolerated in the past, Jack is now instructed to stop eating these foods. The mother did note slight fussiness with the positive food after she found out the test results. It's kind of confirmatory evidence. The other thing that Jack B's mom does, which I think is devastating, is she joins a food allergy support group. Okay, so that's Jack A and Jack B. Let's see how they turn out. Jack A, 5-year-old Jack, enters kindergarten with no food restrictions. His weight and height are at the 50th percentile. He's in good health. Jack makes lots of friends and is a happy child. Now, who doesn't want to have Jack A or to be Jack A? Jack B is also 5 years old. He enters kindergarten with numerous food restrictions, including milk, egg, wheat, and peanut. The school nurse is given an EpiPen, an epinephrine autoinjector, and instructions for its use. Autoinjectors are also stashed at various locations in the school. The mother demands that the school be made peanut-free, since even casual exposure could kill her son. The other parents become resentful. Jack has experienced poor growth. He's at the 5th percentile for weight. He ingests hypoallergenic supplements. Jack sits at a peanut-free table, makes few friends, and is bullied frequently. That's Jack B. Which Jack would you like to have? It could really go both ways. You've seen this before, haven't you, Dr. Pandya, both of these Jacks?
I've certainly seen both scenarios happen. And I think a lot of the things you highlighted in both vignettes are going to highlight the majority of what we're going to talk about today. How does one diagnose a food allergy? How can a food allergy test be falsely positive, the psychological implications of food allergy, and what can actually result in having a food allergy reaction in individuals who have known food allergies.
So to begin with, we need to know what is food allergy, and I've got a few cases that maybe you can tell me what you think about these. We have an 8-month-old who occasionally vomits after drinking a full bottle of infant formula, but is otherwise happy and growing normally. Does that patient have food allergy?
Probably not. If there's some occasional vomiting, especially, if this description of vomiting is also just spit up that the kid is having, and they're growing normally, there's no certain pattern that it's happening with the infant formula. It's not happening reproducibly every time they have the formula. No, I don't think that individual has a food allergy.
Yeah, he has spit up. I hate that term, by the way, because spit up most parents think that means just a little spit. In fact,
Right.
Spitting up means vomiting all over the place. It's just a euphemism. It sounds cleaner than vomiting all over, but kids who spit up actually vomit a lot. And parents think there's something wrong because it's more than just spit. So I don't know that I like that term. It's misleading.
Right.
What about an 18-month-old who vomits repeatedly, turns pale and lethargic about 3 hours after eating rice cereal with no other symptoms? What's that?
Yeah, this particular scenario is concerning for an adverse food reaction called FPIES. That can happen in a different time frame than IgE-mediated food allergies with different symptoms. Some similar, some overlapping symptoms, but some differences in clinical presentation as well.
Yeah, it's just another one of those adverse. We're not going to spend a whole lot of time going over adverse reactions. It would take hours to do that, but food protein-induced enterocolitis syndrome, or FPIES, is pretty common. Some primary care doctors can identify it. A lot of them are puzzled and don't know what that is. And I've had parents who've gone online and actually diagnosed their own kid. It's very interesting. Allergy testing does not help. A 2-year-old with severe eczema, we just talked about that. It periodically flares up. The mother has blamed numerous foods, but can't figure out why the eczema is still there. What's that? Do you need
That
to
does
leave?
not. Yes.
Okay, why don't you leave and I'll carry on until you come back. Dr. Pandya had to leave because, ironically enough, I think she's in charge of a food challenge. There you go. We do a lot of those at Children's Mercy Hospital. This 2-year-old with severe eczema that flares up, the eczema is eczema, and it actually could be associated with food, as we mentioned, but in many cases, eczema is not triggered by food. And if they can't figure out why the eczema is still there, and she's blaming foods because she wants a food to be the cause, but in many cases, it's not a food. A 3-year-old who reproducibly develops generalized hives, wheezing, and then vomits after eating peanut butter. That's food allergy. Just put that in your mind. If you see that or hear that, that's food allergy. That's classical. The other ones are mostly not food allergy. They might be adverse reactions. 6-month-old eats peanut butter and shortly afterwards gets this rash on his face. The rash is slightly itchy, lasts a few hours. No other symptoms. This is JAK A or B. This is the JAK we started with. Very, very common. It's not really a food allergy. It may be a local reaction, a local allergy, but it never is associated with anaphylaxis. Wipe the peanut butter off, give Benadryl or Zyrtec or whatever, and you don't need to rush them to urgent care, do food testing, and give epinephrine because it's not associated with anaphylaxis. 6-month-old with this itchy rash. The rash gets worse a few hours after egg is ingested. As Dr. Slavin mentioned, foods can trigger eczema. Usually it's more of a delayed thing. It doesn't happen immediately. You get an eczematous rash rather than hives. It also can last for several days as opposed to going away in an hour. That's pretty typical of it, but it is possible for food to trigger eczema. It's not IgE mediated, so allergy testing does not help. 2-year-old, I've had 2 patients with this, ate fruit-flavored candy and develops this rash. The rash is unilateral, repeatable, no other symptoms. Is it food allergy? The answer is no, it's not. This is a condition called Fry's syndrome, F-R-E-Y. It's caused by damage to the glossal nerve, usually at birth with a forceps delivery. It causes, when you salivate, it also causes blood vessels in that part of the face to dilate. So you get this rash because of dilated blood vessels. When you eat food that is highly flavored, such as fruit flavored candy, it may be unilateral, it may be bilateral. It's usually this wedge-shaped thing on the cheek. In children, it frequently resolves as they get older and the nerve heals. In adults who get it, it's usually after surgery for some group or some reason they do an operation on the parotid gland, and then they start sweating a lot. It can actually be pretty hard to control. But for kids, it's usually a self-limited benign condition. So what is food allergy? Well, from the parent or patient perspective, any unwanted symptom that does not have an obvious cause, such as a rash, abdominal pain, constipation and diarrhea, behavior problems, runny, stuffy nose, autism, all of these things have been blamed on food allergy because symptoms unwanted, no obvious cause. Maybe it's a food that at least gives you a cause that you can do something about. Allergy tests do not help. They can be misleading if the tests are unfortunately positive in a kid who's not allergic, which is called sensitization. Then the parents are going to insist on avoiding all of those foods and getting epinephrine and having the school stash EpiPens. And it can be really difficult management condition. Medically, food allergy is an IgE-mediated reaction after ingestion of a food. The manifestations may include hives, wheezing, stridor, vomiting, hypoxia, hypotension, and death. Death is pretty rare. In other words, anaphylaxis. In this case, allergy tests may help because it's IgE mediated. So that is a true food allergy. Other types of reaction, we call them food intolerance or adverse food reactions, but they're not true allergies. This could include things like food poisoning, scombroid poisoning, which is when certain fish develop a lot of histamine, and then you're basically eating histamine. It could be pharmacologic reactions, intolerances, such as lactose intolerance. I see a lot of that, actually. It's pretty common. The thing about this is that allergy tests do not help. But parents will often insist that tests be done, and a lot of times they are done, but they don't help. Food allergy prevalence is, in kids and adults, it's a little bit different. Kids often will be sensitive to milk and egg. Those are the two most common things in children. What's nice is that most children will tend to outgrow their milk and egg allergy as they get older. So you see that in adults, it's actually pretty rare to have a milk and egg allergy. Peanut is more common in children, 0.8%. Based on challenges, based on report, it's actually more like 1.5%. Tree nuts, fish, shellfish, and others are less common in children, but they're more common in adults, especially the shellfish. Most kids don't eat a lot of shrimp and lobster. You can see that there has been an increase in food allergy, particularly peanut, over the years. This is 2005 through 2014. The prevalence of peanut allergy has increased. And as a percent of births, as well as just overall emergency room visits for peanut allergy. And we'll go into the reasons for that in a little bit later. So when I'm evaluating a patient with possible food allergy, and like I said, we even have just clinics devoted to food allergy. It's just such a common condition now that people are worried about. I always ask, has the food of concern ever been eaten? If they come in complaining of peanut allergy, did your child ever eat peanut? If they've never eaten the food, why are they worried about it? What's the concern? After all, a food has to be eaten to cause anaphylaxis. If you just see the food, or if you're near somebody else who's eating the food, or if the peanut shells are on the floor at the ball game or whatever, that will not cause anaphylaxis. The history of ingestion determines the pretest probability of anaphylaxis. I'm sorry if I sound like my diagnostic testing talk from last week, but the pretest probability really is determined by the history of ingestion. I always ask what food was eaten and how much. The food reactions are often dose dependent. If you eat just a little bit, you get a mild reaction. If you eat a whole bunch, you'll get a more severe reaction. The severity of the food reaction is somewhat dependent on how much is eaten. I asked if this was the first ingestion and have they eaten the food since then. A reaction can occur after the first ingestion. How does it happen? It's usually in kids who have eczema. In fact, most kids with food allergy have a history of eczema when they were very young. They absorb food through their skin, and that sensitizes them. If you fully control the eczema, you can actually prevent food allergy by doing that. It may take several ingestions before the parent realizes that the food's a problem. I have parents who say, yeah, he threw up after eating scrambled eggs, but I gave it to him later and he threw up again, and then I realized maybe the scrambled eggs making him sick. If the food has been tolerated subsequently, then he tolerated scrambled eggs after that, then he's not allergic to the food. You can see how the history can be very helpful. I ask how long after ingestion until the reaction occurs. IgE reactions are usually pretty fast, usually 1 to 30 minutes. It can be delayed up to 30 minutes because the food has to get into the stomach, into the intestines, start to be absorbed before it can actually cause the reaction. So it's not like being given an allergy shot and immediately reacting. Sometimes it can be a little bit of a delay. There are certain foods like alpha-gal, which is a sugar allergen that's in mammal meat, can be delayed 3 to 4 hours because it's so tightly bound to the muscle that the muscle has to be digested to release the alpha-gal before it can cause the reaction. So there can be a delay. Delayed reactions are often a sign of intolerance, such as we mentioned before, FPIES, food protein-induced enterocolitis syndrome, lactose intolerance, things like that can be delayed. I ask how long do the symptoms last? It sort of depends on how much is eaten and how slowly it's absorbed. If you eat a whole bunch of peanut butter and it's in your intestines being absorbed slowly, the duration could be hours. If you eat just a little teeny bit and then throw it up right away, then it could be a very brief reaction because there's not much in there. I ask what were the I don't say manifestations. I ask what happened when you ate the food because most people don't know what manifestation means. I'm worried about respiratory, GI, and cardiovascular. Anything that can be life-threatening is something that concerns me. If the patient says they get an itchy mouth, hives, rash on their face, I'm not terribly concerned. The parents find them scary, but they don't really hurt the child. The child's usually doesn't even know they have it, but it scares the parents to death. So then you have to take that into account. And if the patient can eat the food without any symptoms, they do not have food allergy. I'm going to be saying that repeatedly because there's no reason to test somebody that eats the food without a reaction. You're back, Dr. Pandya. Would you like to talk about the history of what you ask about the history of food allergy?
Sure, yeah. So a lot of these things, and as you know, the history is the most important element in terms of when you're evaluating somebody with food allergy. So especially, when you're taking that initial history, of course, you ask, what the food was, how soon after ingesting the food did the reaction happen, what symptoms constituted, the reaction, how long did these symptoms, or the first question here, how long did the reaction last for? Was there any treatment given? Did it spontaneously resolve? The treatment that you did give, did it help? Once that was completed, once that particular episode was completed, have you reintroduced that particular food again, or have we completely avoided that? And then after that, have there been any tests that have already been done, let's say at a different provider's office? And then do you have those results with you? They rarely have those results. I've had some times where they have connection to a portal where they can pull it up and show it to you if you don't have those results with you in the clinic. And then were there tests done for foods that have not been ingested or that have previously been tolerated? So we know that food panels still exist and that they're still ordered by providers. And so they may have been tested for multiple foods, even beyond the one that you're concerned about a reaction for. Once that was evaluated, were you given an epinephrine autoinjector, and do you know how to use it? And then the third thing is, which you would kind of more evaluate, you wouldn't ask the patient necessarily, but is the correct dose on hand for the patient as well? They may or may not need it, kind of depending on what your evaluation shows above, but if it's concerning for an IgE-mediated food reaction that they had, and they do have one, then of course they need to be instructed on how to use it. And then, we now have these written anaphylaxis action plans that are available that they can be given that give instruction on when to utilize the epinephrine autoinjector, when to just observe, when to treat symptomatically with just something like an antihistamine. So, yeah.
So I guess when I asked if any tests were done and do they have the results, a lot of times tests will be done for foods that the patient has been eating, and then the parents want to look for evidence that the patient's allergic to the things that have little red circles around them that are elevated. So they'll say, well, he seems a little bit itchier after drinking milk, or his behavior is a little worse after eating eggs because the test was positive. A lot of times the test wasn't even positive. It was really low, but the lab marks it positive in error, I think, and the doctor will still circle it and tell them they're allergic to the food, and the parents will look for evidence to support the test results. And so I always ask them, did you notice these symptoms before you got the test results? Most of the time they haven't, and then I explain to them that they're just trying to find confirmatory evidence, and they don't need to do that. Pretty much anybody who gets a rash or complains about anything related to a food, if they go to an emergency room, they will be given an EpiPen, an epinephrine autoinjector. A lot of times they're not told how to use it. They're told improper ways of using it. I feel that if they already have one, they might as well know how to use it. If they don't have one, then we can decide whether they actually need one or not. Hidden food allergies. Patients, for example, we'll be talking about hives later, but if they have a history of hives, eczema, behavior changes, or other nonspecific symptom, they look for a food as a cause because it's something you can control. Having something that's idiopathic is very unsatisfying. It's called cognitive bias. It's a confirmatory evidence bias. Basically, they look for a food as a cause, and then they try to make the food be the cause. A real food allergy is usually obvious. My child ate a peanut, developed hives, and then couldn't breathe. That's food allergy. If you come in and say, well, I think he might be allergic to some food, I'm not sure what, they don't have food allergy. If they say my child acts up, eczema flares, hives get worse, I can't figure out what food causes it. One time he got hives after eating pizza. Was it the pizza? They want a pizza test. Do a pizza test. Basically, if they suspect that a hidden or unknown food is the cause of their symptoms, it's not a food allergy. Patients with real food allergy, they come in and they tell you, I ate this food and I had this reaction. It's usually really obvious. Do you agree?
Yeah, generally, if they're looking for explanation of chronic conditions such as autism, chronic urticaria, atopic dermatitis, and trying to identify that just as one food causing the whole thing, that's not what we define as a food allergy. As we talked about in the last talk, some eczema may be flared by certain food allergens, but again, we're not speaking about an IgE-mediated food allergy at that point.
But they can tell you, he ate egg and his eczema got worse. It's usually connected, and they can tell you. About tests, we already went over diagnostic testing, but it's worth repeating. We do a test to confirm the diagnosis when we're not sure which food was it. If you ate a bunch of foods and maybe one of them caused the anaphylaxis, but we're not sure, we can do a test. We can define the mechanism. Is it IgE or not? We can repeatedly do the same test on an annual or biannual basis to monitor disease activity, see if they're outgrowing food allergy. And if they start out with a relatively low specific IgE that slowly decreases over time, we can predict that they're likely to outgrow the food allergy eventually. We test for foods that are suspected to have caused a reaction. Food that they believe they may be allergic to, I try to discourage that unless there's a specific reason why they think that. If they just have a neighbor who reacted or their great-grandfather had an allergy to shrimp or something, I try to discourage from doing a lot of testing unless there's a specific food that is suspected to have caused a reaction. And in that case, I'm really opposed to food panels, especially panels that combine aeroallergens with foods, childhood panels and stuff like that. Those are really bad. Don't do those panels. What do you think?
Yeah, agreed. I think, we as allergists know that targeted testing is and it goes back to the whole, what's your pre-test probability and why are you ordering the test to begin with?
Yeah, don't order a test unless you're ready to interpret the results. But why are we really doing a test? The test is done if the result can change the treatment. If the treatment won't change regardless of the test, don't do it. A patient who can eat a food without a reaction is not allergic to that food and doesn't need a test. That's the second time I've said it. It bears repeating. Do not order food panels that contain foods that are not of concern unless there's a reason to do so. I mean, if they think they're allergic to tree nuts and there's a panel of different tree nuts, sometimes that can be convenient rather than ordering individual nuts. But just ordering a panel of a variety of foods is just a bad idea. The goal is to determine the likelihood that it is safe to eat the food, right?
Yeah, no, for sure. And I'm glad you mentioned when we talk about food panels, we're not talking about evaluating other foods that fit the cross-reactivity pattern of your food, like peanuts and tree nuts or seeds or something like that. We are talking about broad food panels that test for everything under the sun, including, things that the patient is tolerating and eating without having any reactions.
Yeah, the childhood food panel should not be done. You do a test if doing the test has the possibility of changing it. If they've eaten peanut and had anaphylaxis, you're going to tell them to avoid peanut and carry epinephrine. Now, you might do a test in order to monitor disease activity, but you don't need it to make the diagnosis. If the patient is eating peanut butter, then you don't need to do a test because they can just eat the peanut butter. If you're not sure, if the reaction is unclear or it sounds like it might be anaphylaxis, could be vocal cord or panic attack, there's all these things. You can do a test in those cases, and it may make a difference in terms of the treatment decision. So which test do you do? Well, the history of ingestion is the most important test. If the patient can eat the food, they do not have food allergy. This is the third time I've said that now. Bears repeating. If the patient consistently has a systemic reaction after eating a food, they have food allergy. The mechanism isn't that relevant. Now, technically, they don't have food allergy if there's no IgE, but if they have anaphylaxis after eating a food, they should avoid the food. I don't care if they're allergic to it or not. Food cause anaphylaxis should be avoided. And if they've never eaten the food, why do they care? Can you think of any other reason?
Yeah, that sums it up pretty well. A skin or blood test is not going to change if the patient had anaphylaxis. If the patient had anaphylaxis to a food, the clinical history puts them at a high pretest probability that they have a food IgE-mediated food allergy. And so, yeah, that's an important thing to kind of take into consideration. You also shouldn't wait to prescribe epinephrine until you get the result of a test. That should be prescribed based on the clinical history itself. And then, of course, we know we have the two methods of doing testing, which includes skin prick testing, percutaneous skin testing, or in vitro blood testing.
How do you decide which one to do?
Yeah, I think there's a variety of things that kind of go into that. And so,
Well, actually, I have some.
Sorry.
Let's look at some information.
No, yeah, go ahead.
And then we'll decide. Prick skin test for food. There are pros and cons. Antihistamines can interfere. Skin tests should not be done if there's dermographia. I've seen that. Patients have dermographia, they get hives. Somebody does a skin test and everything's positive, so they're told they're allergic to all this stuff, when in fact it's just dermographia. Don't do a skin test if there's dermographia. Intradermal tests are not done for foods, just don't do them. There is an issue with coefficient of variance in skin tests. It's pretty high. There's a lot of variability in skin tests, and the coefficient of variance is pretty high. It's the standard deviation divided by the mean. For a clinical chemistry test, you want it to be less than 5%. For food allergy, it tends to be anywhere from 16 to 40, 55%. With a variance that much, it sometimes is hard to tell the difference between a positive and a negative. So it is pretty variable, and I don't find it useful for monitoring over time because of the variability. It's not repeatable. There are these positive predictive values, and remember the limitations of PPV. It depends on the prevalence in the population. But if cow's milk is greater than 8 millimeters, there's a 95% positive predictive value. What if it's 7 millimeters? That doesn't really help. I really would rather know the probability given whatever result you get. Whereas the in vitro test, this is our immunocap machine in our laboratory. Right now, as far as I know, this is the only brand of IgE test that's commonly done in clinical laboratory, so it's not a conflict of interest for me to say that this is a Thermo Fisher product, that this is the test that will be done. And again, there are serum IgE values associated with 95% positive predictive value. It again depends on the prevalence in the population, so there's limitations. And for egg, if it's greater than 7, then you're probably allergic to egg. What if it's 6? I find it to be difficult to use this table to make a decision. So, are you still there, Dr. Pandya? Or did you have to go do your challenge? It looks like she had to go do her challenge. We see this all the time, and I showed you this before. The sigmoid curve is wrong because you can have a low IgE antibody and still have anaphylaxis. It's a false negative, but it's actually the test is what it is. And sometimes the test might not give the same. It depends on the pretest probability, really. That's why this is not helpful. What you need is likelihood ratios, like I mentioned before. For peanut, you can get a curve that shows what the likelihood ratio is for each value of peanut-specific IgE. There's a regression formula. This can go into a computer-assisted diagnosis model, which is being developed, and it will tell you the probability that the patient's allergic to peanut given the likelihood ratios and using a Bayesian approach, as we talked about last week. And we can do the same thing for baked egg and for unbaked egg. And I've already showed you this, the probability of food allergy. If you didn't see it last week, let me just review it again. We want to know the probability of food allergy. It's either not, they don't have food allergy, or they do, 100%. It's usually somewhere in the middle, and if you don't know anything about their probability of food allergy, then you estimate the prevalence in the population. That's something that those positive predictive values in the previous studies did not include, information about the prevalence in the study in the population that was studied in those studies. So it makes a big difference. The Bayesian approach, you start with the prevalence and you go from there. If you do a history and it's positive, then your probability of food allergy increases. If it's negative, it decreases. In this case, let's say it's a positive history. If you want to know more information, you can do another independent test, an allergy test perhaps. And if it's positive, then you're even more likely to be allergic to the food. If it's negative, then you're much less likely to be allergic to the food. Eventually, you'll reach a probability that's high enough or low enough that you can make a clinical decision and get on with the treatment. That's the approach that we use for making a diagnosis. And don't forget the McGee. There's the Fagan nomogram, which I think is a little cumbersome. The McGee heuristic is much easier to use. If the likelihood ratio is 1, it doesn't change the probability. If it's a very low likelihood ratio, like 0.1, there's a 45% lower probability of having the disease. If the likelihood ratio is a high number, like 10, which is pretty high, then there's a 45% increase in the probability of having the disease. You can use this heuristic pretty simply, I think. Once you know the likelihood ratio, you can estimate the probability the patient has the disease. So for food, here's a decision tree. If the patient eats, if the patient eats the food and does not react, then the risk is very low. You can see different values of IgE test, and then the new risk. Basically, we've done the math for you with the likelihood ratios, and the new risk really doesn't change. So if the patient ate the food and didn't react, don't do the test because you're still going to recommend that they eat the food. If the patient ate peanut and had anaphylaxis, a systemic reaction, there's a very high initial risk, then pretty much no matter what the IgE test shows, you're still going to tell them to avoid the food, even if the test is negative. It's not a false negative. It just means that the likelihood ratio was low, but it wasn't low enough to overwhelm the pretest probability. Where this really shines is when it's unknown. You shouldn't be doing tests in patients who haven't eaten the food, but they get done all the time, and then we're asked to interpret the results. We clean up the mess of people who've ordered tests when they shouldn't have been ordered, basically. If the IgE is low, they can eat the food. If the IgE is high, they can avoid the food. If the IgE is in the middle and we're not sure, we can do an oral challenge, which is really just another independent test that gives us more information because we don't have enough to make a decision. So, okay, Dr. Pandya, how probable does the risk of anaphylaxis need to be to advise avoidance?
So the risk with regards to anaphylaxis, if there is a clinical history that's, concerning for that, and we kind of determined the like prevalence of the population having peanut allergy, we determine the likelihood that the patient is going to have a reaction. Then what's written out here is that the prevalence is 1.5%. If the risk is less than 1.5%, the peanut should be eaten. Sorry, I'm kind of jumping back in right after I saw this patient.
Yeah, I know.
Yeah.
I caught you off guard. You got to.
Yeah. Sorry
catch
about
up.
that.
Basically, we're assuming that we know the risk now. We've done the Bayesian analysis. The computer has told us
Okay.
the risk of food allergy is blah blah blah.
Okay.
How
Gotcha.
do we use that to advise it? If the prevalence is 1.5 and the risk is less than that, then it's even safer to eat food than you would if you just were eating it for the first time. So of course you eat the food. What if it's greater than 1.5? There's a lot of factors that enter into this, and I'm sure you've run into these factors.
Yeah, it depends on what the individual family or patient's risk is with regards to, taking that chance and ingesting the food and seeing what happens. Some families have a different risk threshold, so all of that needs to be kind of determined and have a shared decision making prior to determining the best mode of action. Do you do a home introduction of the food? Do you introduce the food in the clinic? Are they not even open to either of those options?
Yeah, I mean, if the risk is 5 to 10% of having a reaction, that means there's a 90 to 95% chance of not having a reaction. We always portray it in the wrong way. We should say what the likelihood is you can tolerate the food and not have to deal with food allergy. To be really nice. Some families are okay with that. I've had families where I said maybe we should do an oral challenge in the clinic, and they say, well, can we just do it at home? Because they don't want to come into the clinic to do a challenge. And if it's 5 to 10%, sure, go for it. I'm okay with that. Other families, if you just mention the mere mention of trying it at home, they're terrified. They're just upset. Some of them, they will call the patient advocate and say, you're trying to kill my kid. It's just amazing how terrified some families are with just merely mentioning that they come in contact with the food. There's a huge spectrum of risk aversity in families, but almost all families can share anecdotes about food allergy. I had a neighbor whose kid died from food allergy. I had a patient who was positive and he still ate the food, and it doesn't mean anything. They can tell you anecdotes about food allergy. It's called the availability bias. I'm into cognitive biases because this really does affect how people look at these medical conditions. I like to show this slide. If a patient has a anaphylactic sensitivity to food, and what is the risk of actually dying from that food? And the risk, I think I showed it last time on the diagnostic testing thing, was about 1 in a million. It's actually very rare that somebody dies from food anaphylaxis. Most people who have anaphylaxis don't die from it. And like I said, the risk of dying from death due to murder in the United States is far greater. We should be giving our patients bulletproof vests instead of EpiPens. That's just tongue in cheek. I'm not advocating that. I'm just pointing out that the data could support that. Do you ever do components?
Absolutely. We know that multiple foods now have component testing available. And so I regularly do this testing in the clinic.
Yeah, there's all these different protein families. They're kind of alien sounding. You don't really have to know them. But some of them are unique. Some are cross-reactive, like profilins are found in lots of different things. BetV1 and FeLD1 are unique to those allergens, birch and cat. Some of them cause mild symptoms. Allergy to others cause more severe symptoms. And it's largely because some of them are labile. They break down very easily. And some are very stable and don't break down. The stable ones tend to cause more symptoms than the labile ones that break down. So here's a scenario about milk allergy. A 9-month-old with vomiting and hives after ingestion of milk formula. Would you like to describe this?
Sure, definitely. So here we have the testing. The total cow's milk IgE is reported as 12.3. Then we have two heat labile proteins, the alpha-lactalbumin and lactoglobulin, that's reported at 2.2 and less than 0.1 respectively. And then the heat stable protein casein, which is reported at 8.5. So with the cow's milk IgE, with the casein being high, we know that the likelihood of cow's milk allergy is high, specifically with casein with regards to baked milk. We know that the likelihood is high as well. And we correlate that, of course, with the clinical history that's written above, vomiting in hives following ingestion of the formula.
And then the elevated IgE supports the high likelihood of a reaction.
Mm-hmm.
And then we did the components, and the high casein suggests that the patient will not tolerate baked milk because casein is heat stable. I mean, if they didn't have any casein IgE, then baking the milk would probably help because the other two components are labile and will break down when you bake the milk. So the recommendation is avoid milk, both cooked and uncooked, and monitor the IgE annually because this child may in fact outgrow milk allergy over time. Here's another one, egg. This is a 1-year-old with no history of ingestion, patient who has eczema, and somebody decided to do a food panel. How would you interpret this?
Yes, so we have the entire egg white IgE, which is reported at 0.7. We have the heat stable protein called ovomucoid IgE, which is reported as less than 0.10, and ovalbumin, which is heat stable, partially heat stable, I should say, which is reported at 3.5. Now we're contrasting this with the previous clinical scenario, where the previous clinical scenario had urticaria and vomiting, I believe, and then this one is no history of ingestion, yet you see sensitization here. So the sensitization alone does question, you could have an increased risk of reaction, but the test alone for that shows about 5 to 10%, not taking into account, again, the clinical history. And then the ovomucoid essentially being absent here, that's essentially saying that your patient may be able to tolerate baked egg for sure. And so you can certainly consider doing a baked egg challenge. Now, practices on this vary. Some people will say you can introduce it at home. Some people will say you can introduce it in the clinic with this particular clinical history. So that has to be taken into consideration. And then the last thing is, if you have no history of ingestion and this is the testing itself, let's say that, baked milk is introduced into the diet, or even, independent of that, would you consider a challenge anyway in this patient, given the risk already that's there, 5 to 10%, but knowing that the patient has never ingested the food?
Yeah, and the 5 to 10% was calculated based on the prevalence, and then we did the Bayesian analysis with the likelihood ratios. Food challenges. Do you want to talk about food challenges?
Absolutely, yeah. So
why you're doing one right now, aren't you?
I'm doing one right now.
Well, tell us, why are you doing a food challenge?
So outside of research purposes, when we do it for clinical purposes, and I say that also because I'm doing it for a research purpose today. So anyway, why do we do an oral food challenge? So if the diagnosis is uncertain, to confirm the diagnosis, or if you've kind of monitored a patient over time for a certain food allergen, let's say peanut for an example, we know that there's about a 20, potentially even 30% chance that they may outgrow it over time. Once the skin or blood tests, and I think this talk specifically we highlighted on the blood tests, look favorable, you can consider offering an oral food challenge. And the reason to do this essentially is if the risk threshold is low enough, and the likelihood that the patient has the allergy is low enough, why wouldn't you avoid all of the other bad things that come with avoiding a food? Why would you not reintroduce the food in the diet? So how is a food challenge performed? Generally, this is performed in a clinic. It can be done as open, single blind, or double blind with placebo controls. So there's multiple ways that we do it. And generally, these are done with graded doses. And when we are talking about that, we are talking about, IgE, allergy, food challenges. There are some protocols beyond this talk for FPIEs that do a single dose for an entire food given together. But again, that's for FPIEs. It's not talking about this specific talk addressing IgE-mediated food allergies. Generally, the food is doubled at an interval of about 15 to 20 minutes. And again, highlighting on what I just said here, what is the goal? To determine if the food can be safely eaten. And so we're essentially proving if that can be done in the clinic when we're observing the patient. And then other issues, are rashes a reason to abort a food challenge? I think this, question is definitely coming up quite a bit and has made for a lot of discussion at our last two conferences. And then should H1 antihistamines be avoided prior to a challenge? Again, that's also a point that kind of comes up. And I think people have various perspectives on this. One perspective is that if rash is the only thing that a patient develops with the food, then do they need to avoid the food? And then the second thing is, if antihistamines do not prevent the progression to anaphylaxis, do they truly need to be avoided with an oral challenge? One other part to that, one other perspective I should say to that is, if someone is thinking that with symptoms that occur with a systemic reaction, of course, we think of cutaneous, we think of respiratory symptoms, we think of cardiac symptoms. If the cutaneous symptoms are kind of early on occurring in the allergic reaction, would you abort the challenge at that point? That's one perspective that people can have. And you would be off of antihistamines so you can see that, clinical thing happen. However, different people have different opinions about that. And some people do not avoid H1 antihistamines prior to a challenge, nor do they abort the challenge due to a rash developing. It also depends on how much sometimes of the rash that the patient is developing, meaning widespread urticaria covering the whole body versus maybe like a couple patches of erythema here and there. Yeah. So what's your perspective, Dr. Portnoy, on this?
It's probably a little bit different than other people's. Yeah. The purpose of the challenge is to see, is it safe to eat the food? I don't care if they're allergic to the food and get a rash. If that's all they get, it's still safe to eat the food, and maybe they can eat the food and not worry about the rash. If you don't give an antihistamine and they get a rash, sometimes they want to abort the challenge because they see this rash and it scares them. If you've taken an antihistamine, they don't see the rash, they continue on. The purpose of the challenge is to see if it's safe, and you won't know if it's safe unless they've actually completed the challenge. If you abort it in the middle, you really haven't accomplished anything, especially if it's just a rash. You don't know if it's safe or not. And what's the point of doing challenge then if you're going to do that? That's just my opinion. Food avoidance, when I was first training, and somebody was allergic to a food, we would just say, oh, we'll just avoid the food. What's so hard about that? Don't eat the peanut, don't eat milk, don't eat egg, whatever. And there's a few things to keep in mind. Casual contact will not cause anaphylaxis. You have to eat the food to have anaphylaxis. That's why we call it a food allergy. Skin contact commonly causes a rash, but it's not anaphylaxis. Patients do not need to avoid flights in which peanuts are served, even though peanuts aren't being served anymore. Baseball games, restaurants with peanut shells, all of that stuff, that does not cause anaphylaxis. Peanut oil, refined oil does not have peanut allergen, can safely be eaten. My patients all avoid Chick-fil-A until I told them, you can eat the peanut oil, it's not going to hurt you. Then they're so grateful. And then these signs produced in a factory that also handles peanut. It's a legal thing. It's a very low risk. There was actually an article in one of the journals about this where they measured the amount, and it's extremely variable. Produced in a factory really is not predictive of whether there's actually the food in it or not. But why not just avoid the food? And obviously, you can get vitamin and mineral deficiencies with a restricted diet. That certainly is compelling. But I think these are the psychosocial harms that are much more important. When you tell somebody they're allergic to a food and they have to carry epinephrine or they could have anaphylaxis, which is life-threatening, creates anxiety and fear. They live with constant fear of actual exposure to their allergens. Social isolation, People with food allergies can be isolated from social activities that involve food, and don't most of our activities involve food. They may avoid eating out. They may not attend parties or social gatherings. They're not sure about the safety of the food. There's a stigma and misunderstanding. They can be misunderstood by others. So people might dismiss the condition and say, oh, well, you're just making it up or something. Some may not comprehend the severity, making it hard to navigate social situations. Children get bullied and teased. Even adults with food allergies may face it due to their dietary restrictions, and it can lead to decreased self-esteem, negative emotional impacts. Do you want to go over these?
Yeah, absolutely. So in terms of the family dynamics as well, meal planning, if one person is eating the food in the home while the other isn't, also fear of, having even some of those food allergens in the home, those can all be another, psychological implication on the family. Dietary restrictions and limited food choices. So this often restricts the option of foods that the patient actually has to eat. Sometimes they completely avoid eating out. The satisfaction that they have with their meals also can go down as well. And then the financial burden. So allergen-free foods are not cheap. In fact, they're often more expensive if you look at them in grocery stores. And so this can put undue stress onto the family as well. One question that you want to kind of think about is, if someone is appropriate to, offer a food challenge and you're considered doing that versus just avoiding the food, who is avoiding the food easier for you as a provider or the patient? And I think a lot of these things that we highlighted here just kind of show how much harm can come from unnecessary avoidance of a food and living with a food allergy too.
That's a really important point. The question is it the patient who's afraid of eating the food, or is it you? And if the patient would be okay trying to eat the food, but you're afraid of it, I don't think that's fair, because you're really causing harm to your patients, and that violates the Hippocratic Oath. If the patient feels comfortable trying the food at home or whatever, let them do it. If you're afraid, you can explain your fear, but they're going to do it anyway. I think that you really need to separate those two. That was a great point. Anaphylaxis. Patients who are increased risk of anaphylaxis should be given an anaphylaxis action plan. The treatment of anaphylaxis is epinephrine. There you go. This patient is holding their epinephrine autoinjector correctly. Antihistamines may prevent progression to anaphylaxis. So if a patient gets a rash but doesn't actually have anaphylaxis, giving an antihistamine may prevent progression, so they don't need their epinephrine. H2 blockers have no proven benefit for the treatment of anaphylaxis, so they don't have to be, doesn't hurt to give them, but they don't need to be given. And steroids have no proven benefit for the treatment of anaphylaxis. They've not been shown to reduce the risk of a late phase reaction. So you don't have to give steroids either. This is our anaphylaxis action plan. We developed this at Children's Mercy Hospital. There are many plans. There's the fair has a plan. The academy and college both have plans. Everybody has plans, but they all seem overly complicated and difficult to figure out. This seems like a pretty simple plan, and that's why we developed it for our clinic, because it is simple. Basically, you tell them just to observe if there's no reaction. If they treat it when there's no reaction, they might have outgrown it, and then how will they ever know unless you don't treat it? Once they start getting mild symptoms, give an antihistamine and see if it can prevent the progression to anaphylaxis. Once they develop anaphylaxis, which is the bottom box, use epinephrine, give an antihistamine. I don't tell my patients to call 911 automatically. If they use one EpiPen and they have two of them and it responds right away, the parents can watch and see what happens. If it recurs and they have to use their second EpiPen, then they can call, they can at least seek medical care. I don't know if they need to call 911 because they're out of EpiPens. The reason I'm not telling them to immediately call 911 and go into the emergency room partly is the cost. I've had patients refuse to use their EpiPen because they didn't want to have to call 911. They didn't want the $6,000 ambulance bill and another $6,000 emergency room visit. They don't want that. They really don't. So don't tell them they have to do it, because then they'll just lie to you that they did, or they might not use their epinephrine at all when they really need to use it. think Dr. Pandya is doing her challenge. Remember, here's the strategy for diagnostic testing of food allergy. You get the pretest odds based on the history following exposure, and if there's no history, the prevalence of food allergy in the population. Test for specific IgE to get the likelihood ratio. It's a skin or blood test. There are more and more likelihood ratios becoming available, although right now your lab won't report those to you. You need to insist, or at least demand, that your lab start reporting likelihood ratios. Determine the likelihood of having symptoms with exposure, the post-test odds. Then you need to figure out what to do about it. Eat the food, avoid the food, carry epinephrine, maybe oral immunotherapy, and possibly do an oral challenge if you're not sure. So do you want to talk a little bit about oral immunotherapy for peanut?
Absolutely, yeah. So taking a step back with regards to immunotherapy, there are, of course, some options for foods that are largely research purposes. You know, we have oral immunotherapy, we have epicutaneous immunotherapy, we have patches of, foods that we can put on patients. But currently, the only FDA-approved immunotherapy is the one listed on this slide here for peanut. This was approved by the FDA in 2020, and it's a standardized peanut flour. Now, when we say standardized, it has an equal amount of all of those ARA-H proteins, I believe, that we highlighted earlier in the talk. There's two phases to the treatment for this. The first is when you have something called the initial dose escalation, also abbreviated as IDE. With the IDE, they receive in one visit multiple doses of the peanut OIT, again orally, up to 6 milligrams. That first visit, then, they go home, they come back within 1 to 4 days, and then they updose to 3 milligrams. Every 2 weeks after that, you updose higher and higher until you target the maintenance dose at 300 milligrams. And to give us one more reference range, when we think of 2 tablespoons of peanut butter, the serving size for patients who are a little bit older, that's about 8,000 milligrams of peanut protein. So when we contrast that, we're starting at 0.5 milligrams, and we're targeting a maintenance dose at 300 milligrams. In the New England Journal study, we saw that at this dose, about 66.7 or 67% of patients who then underwent an oral food challenge up to 600 milligrams of protein, peanut protein, passed without having any systemic issues. With this particular therapy, there are some side effects. Of course, there's anything on the spectrum of anaphylaxis. You can develop hives, angioedema, vomiting, diarrhea, difficulty breathing. All of that can happen at any point during any of the updoses. However, kind of more common side effects that can occur at any point during the therapy do include itchy mouth. You can have some GI symptoms as well. And then there is kind of a rare side effect, but one that families or patients should know about, which is the development of EOE while on immunotherapy as well. One thing you have to counsel patients or talk to them about is what is the goal ultimately of oral immunotherapy? Because with this therapy, we don't allow the patient to freely eat the food in the diet without any restrictions. However, it is a desensitization as listed on the last point here, and it helps prevent reactions to accidental exposures or reduces the potential severity of a reaction if someone were to undergo one, again, with an accidental exposure. But they still have to avoid the food and everything as if they have a food allergy. They do have to carry EpiPens while they do this, and generally this has to be done in a supervised setting.
Well, that's how you can treat an allergy. At least you can better manage it. What about preventing it? I mentioned at the beginning that there's an increased incidence of peanut allergy, and there's a reason for that. And one of the result of the studies that came out of understanding that reason is the Learning Early About Peanut, or LEAP study. It's probably the most described study in all of allergy. Basically, the patients who were enrolled were high risk of developing peanut allergy. They had severe atopic dermatitis, which in our last talk we mentioned is a very strong risk factor for developing peanut allergy. If they already have a food allergy, like egg allergy, they're also at high risk of developing peanut allergy. Would you like to describe the results of the LEAP study?
Sure, yeah. So this was an intention to treat analysis. We have 3 different charts here, kind of all listed together. At the bottom, we're seeing if a group was an avoidance group, essentially they avoided, the food allergen, or the second was, whether they consumed the allergen. And then on the y-axis, we're seeing the prevalence of allergy if they were skin test negative, first chart to the left, skin test positive, middle chart, or both cohorts kind of combined together. So we can see in the avoidance group, the prevalence of allergy, again, in individuals who avoided the food. So development of the allergy was at 13.7%, whereas in the consumption group, it was at 1.9. Again, this is in individuals who had skin test that was negative. Now we go to skin test positive. So in the avoidance group, the prevalence of allergy, or, seeing if they developed it, was 35.3%. Again, this is in the avoidance group compared to the consumption group, those who ate the food essentially, and which was 10.6%. And then when you combine both those cohorts together, the avoidance group, the prevalence was 17.2% compared to 3.2%. And this led to, I believe, the recommendations we're going to talk about here in a second, but essentially what to do. Oh, sorry. Go ahead, Dr.
Go ahead. What do we recommend then?
Yeah, so with regards to this, in individuals who are, first you have to stratify, are they low risk, medium risk, or high risk for, let's say peanut allergy, because that's what this particular study looked at. We're not talking about the E-trial, just the LEAP study here. So if someone is low risk, you don't essentially need to perform any testing in that. If they're medium high risk, particularly with 2 conditions, if they have an egg allergy or if they have moderate to severe atopic dermatitis, you can perform skin testing in these patients. If you perform it, or blood testing, I should say. If the blood testing or skin testing, let's say, is negative, so that's defined as the skin test wheel being less than 3, or the blood test in this, again, based on this being defined as less than 0.35, the food can be introduced, potentially even at home. If the skin prick is between 3 to 7, you can do a supervised food introduction in the clinic. And then same thing for like the blood test level. The blood test, we don't have as much clear guidance on it in terms of what like level, you can do a supervised office introduction versus like an oral food challenge. And then if the individual has an 8 or above in terms of their skin prick, and again, if you're concerned about whatever blood test level that they have, one recommendation that's come out has been to repeat in a year. Now, I will say that that's what the recommendations have been. But different allergists practice different ways with that. Some will still perform an oral food challenge with a skin prick that's 12, say, for instance, even in somebody who was performed for a high risk reason, let's say egg allergy or having severe eczema. So that practice may vary, but ultimately those are the recommendations that came from this trial.
Yeah, and as you said before, are we dealing with the fear of the allergist or the fear of the patient? I think here we're dealing with the fear of the group that made the recommendations, because there are some families that would still be happy to introduce it at home, even if you consider them to be medium risk. So this is an ideal opportunity for shared decision making with the patients. I need to point out that this is in patients between 5 and 11 months of age.
Yes.
There seems to be a critical window. And so introducing peanut between 5 and 11 months of age, ideally before they've actually become sensitized, is the best way that we know to prevent peanut allergy. I guess fully controlling the eczema in kids who are less than that so that they don't become sensitized to begin with. But once they're becoming sensitized, early introduction of peanut is absolutely recommended, and we encourage it in our patients. The old recommendations were to avoid peanut until 2 years of age. That's what caused the epidemic of peanut allergy. Early introduction is the way to prevent it. So, I don't have more details about that, because we could go on for a long time, and we're out of time. Here are the heuristics. Heuristics are rules of thumb that you can follow. If there are no symptoms following ingestion, the patient does not have food allergy. That's the 4th time I've said it. I think that's all I have. If the patient suspects that a hidden food is the cause, it's not a food allergy. It's not. A food has to be eaten to cause anaphylaxis. Do not order food panels that contain foods that are not of concern unless there's a reason to do so. The goal of diagnosis is determine the likelihood that it is safe to eat the food. And the food avoidance causes significant damage to the patient and family's quality of life. So don't do it lightly. It can really cause harm. To summarize, it's a common complaint. The most important test is the history. If the food has not been eaten, the probability is the prevalence. The test is done to update the pretest probability of a systemic reaction when the decision is not clear, to confirm the mechanism as IgE, estimate a prognosis, and to monitor allergy over time. Treatment choices include avoid the food, carry epinephrine, consider oral immunotherapy if they have peanut allergy, perform an oral challenge if the risk is unclear, introduce the food into the diet, either at home or in the clinic if the risk is low. Early introduction of peanut, and there's some evidence for egg also, between 5 and 11 months can reduce the risk of developing peanut or egg allergy. Do you have any other points that you wanted to make, Dr. Pandya?
No, I think that's everything. Dr. Miller, sorry, we went a little bit over time on this one.
But this is such an important topic. So I guess
It
we'll
is,
stop
and
now and turn it
it's a
back
primary
over to
diagnosis that we tend to see
Dr.
these days. So for sake of time, I'm going to hold off on questions. You should have the email of the speakers. If you have any questions, you can send it that direction. And for those who didn't get enough, we do have 3 other speakers in the COLA series, this summer series presentation related to food allergy and or intolerance. So thanks again for your guys' presentation today. Appreciate it.
Thank
Thanks,
you.
Dr. Miller.
Okay, thanks all. Bye.